So I wanted to kind of talk about some of the facts and some of the myths. And I know everyone understands that what's out there changes pretty regularly. And that's because the longer this disease is among us, the more opportunity there is to learn about the behavior of the virus and how people do when they have it and how they recover. So we'll take just look at things kind of from a question standpoint. What constitutes an exposure to COVID-19? Coming in contact with somebody that has COVID-19 is an exposure. How much contact do you have to have? So you need to be in close contact inside 6 feet for more than 15 minutes if nobody's wearing a mask. That would be considered close contact. If you pass somebody on the street who has COVID and you just walk by them, you're probably not going to get COVID unless they look at you and sneeze in your face. That would not be good. But generally speaking, casual passing people is not as big of an issue. If you touch a surface that someone has sneezed on or coughed on and then rub your eyes, you probably would get it, even though that person just kind of walked by you, but they sneezed on the elevator button and you got on the elevator and pushed the button and then rubbed your eye. Well, then that would be an exposure. So if you've had an exposure, what do you do? Everybody wants to get tested. Oh, I got exposed, so I need to go get tested. Well, the first thing you need to do is stop and think about, are you sick? And what is the need for having the test? Everybody wants to know, but if you have a test at the wrong time after your exposure, the wrong time frame, the test is not going to be valid. It's not going to give you the information you really want to know. So typically, if you're exposed and you're going to turn positive, that will not happen for 3 to 5 days after the exposure. So testing in under 3 to 5 days is of no value. A negative test during that time frame still doesn't mean you're negative. You could still be positive, you're just not there yet. So if you had a test 5 days afterwards and it was negative, and 2 days later you started having symptoms, you might well need to be tested again, because the timing may be what made the test in error. If you had an antigen test, that rapid test, 5 days after exposure and it was negative, you need to have a PCR test, because the false negative rate of the antigen test is sufficiently high that if you're really suspected of having COVID, in other words, you're having symptoms, you're sick, you may have fever, cough, congestion, pneumonia, those people, when we admit them to the hospital, if we really think they have COVID, we do an antigen test. If the antigen test is negative, we do the PCR test. If the antigen test is positive, the constellation of the patient's symptoms combined with a positive antigen test confirms the diagnosis of COVID, and we move forward from that. So I think we've addressed the issue of, is the more positives we're seeing due to more testing? It's not. I mean, you can look at all of the numbers everywhere, and it's not more testing that's causing it to be positive. Another concern is, well, people get tested multiple times that are positive. Does that just drive the numbers up? No, it doesn't. It's 1 positive per patient. So they're not counted multiple times. Are people's death certificates marked positive because the hospital makes more money if somebody dies and they say it's a COVID death? No. The only reason somebody's death certificate would say they died from COVID would be if in fact they died from COVID. And they would have to have tested positive and had a constellation of symptoms that constituted COVID for COVID to be attributed as the cause of death on the death certificate. Does the hospital get compensated for taking care of COVID patients? There is some additional compensation. It's about 20% of what Medicare usually would compensate the hospital for pneumonia. So typically with pneumonia, people are in the hospital 3.5 days. COVID patients that are really sick are in the hospital anywhere from 7 to 35 or 40 days. So that 20% increase in compensation does not cover, does not cover that, but it is something that helps defray some of the cost. Locally, we've heard that locally we're not seeing much COVID. Actually, we are. Locally, all the numbers we have here at the hospital indicate it's going up. Physicians that I've talked to who treat adults have seen an increased number of positive cases in their practice. Interestingly, a lot of these positive cases are not sick enough to be admitted to the hospital, but they're still positive and they're being sent home, which kind of goes back to it's very important for people that are positive and are at home to isolate themselves from other people to reduce the risk of transmitting it to somebody else, because COVID is highly transmissible. And that's where you get into what you've heard about the death rate. So the death rate is so low from COVID, we just shouldn't be that worried about it. Well, you worry about absolute numbers, not percentages. So when COVID is infecting 2.5 times more people per infected person than the flu, that's a logarithmic change in the number of people infected. So you get into the millions of people quickly. And a small percentage of a large number is a larger number of actual people sick and dying than a small percentage of a smaller number. So it is significant. It is a significant issue, the mortality rate from COVID just by itself. When you look at the number of people we have in the hospital, as I mentioned, in the hospital right now we have 6 patients on a ventilator. Typically, patients on ventilators with COVID have about a 40% mortality rate. That's down from about 51% a month ago. And a lot of that difference is felt to be due to 2 treatments, dexamethasone and remdesivir. So Decadron, dexamethasone, is a steroid that's been being used for severely ill patients with COVID, and it has shown a dramatic decrease in mortality. Remdesivir has been shown, it's an antiviral drug, and it has been shown to decrease the length of stay of patients with COVID. So the study that was done showed that people recovered faster if they took remdesivir as opposed to not taking remdesivir. The study was stopped before it actually confirmed that it reduced mortality. It's felt that it helps reduce mortality, but that has yet to be borne out with studies. As far as the availability of remdesivir, we've been getting it here at the hospital. Up until a week ago, it was donated from a federal level. The lab that makes it donated it, and our state would be allocated a certain amount of remdesivir per week, and then that was allocated to the hospitals based on need. And we've generally done well in being able to get that. Now we're having to request it and purchase it. The problem with that is it's a guessing game. So we look at how many COVID patients we've got in the hospital today, and we try to guess how many we're going to have 2 weeks from now so that we can order remdesivir and have it available. Remdesivir is expensive. It costs about $3,200 for 5 days of remdesivir, and it's not reimbursed. There's no additional compensation for remdesivir. No insurance company pays for it. Government doesn't pay for it. Medicare doesn't pay for it. That's just what it costs, and that's for 5 days. Some patients actually need 10 days of it. When we're talking about treatments, in addition to dexamethasone, which is Decadron, the steroid, and remdesivir, which is the antiviral drug, which is really the one treatment that was studied in a very sophisticated manner, there's hydroxychloroquine, which was the first thing out there that everybody touted is this is what you treat malaria with, this is going to be it, this is going to solve the problems. So since then, hydroxychloroquine has been studied, and it's been proven to provide no benefit. So early on, there was concern and thoughts that it might help, but as time has progressed, a lot of people have gotten it for various situations. It hasn't helped anybody. So hydroxychloroquine adds no value. So it's been said that labs are sending in unused specimens that are coming back positive, and that's why the numbers have increased. I don't know what's happening in other labs. I just know what's happening in our hospital. And in our hospital, when we look at the positive numbers, we're actually looking at real people that are sick, real people that are in the intensive care unit, real people that are on ventilators. So we're counting numbers from that, not just a positive test value coming out of some lab. So the idea that masks will restrict airflow and cause more severe health problems than COVID, and that wearing a mask leads to increased carbon dioxide retention, carbon dioxide intoxication, and oxygen deficiency, those two comments are really pretty laughable to me. The thing about wearing these masks that are effective for COVID are surgical masks. Okay, that's a face mask. So this is a face mask like you would wear in the operating room. I've spent about 40 years of my life in operating rooms as a surgeon. I have not gotten CO2 intoxication. I haven't gotten oxygen deprivation. It's amazing. I hadn't had any side effects from wearing a mask. There have been studies out there talking about N95 masks, that wearing an N95 mask for a prolonged period of time could be detrimental to some people's health. And those studies were done, and those studies are in the archives, so to speak. N95 masks are not what everybody needs to wear to help this problem. Just a face mask or a cloth face covering will work. Anything that blocks large droplets. So it's not necessary to put on a highly restrictive mask to protect anybody. A cloth face covering or just a plain, simple surgical face mask will work. Seat belts are something to really think about. Think long and hard about seat belts. I remember when seat belts became mandatory, nobody wanted to wear a seat belt. Over time, people have adapted to that, and most people wear seat belts. Categorically, seat belts save lives. So wearing seat belts, in spite of the fact that there was a lot of public opposition to wearing seat belts help. Masks, there's a lot of public outcry about wearing masks, but they help. Studies show they help. If you look at the studies that have been done that look at masks, many of them were done just looking at the wearer, not looking at them as source control. The recommendation is to wear a mask for source control, which means if the person who has COVID has on a mask, they're much less likely to transmit it to somebody else. You know, this is not a disease that only affects people over the age of 65. Granted, older people and people with other medical problems do not fare as well if they are severely ill with this disease. So 8 out of 10 deaths in our country from COVID are in people over the age of 60. So that means 2 out of 10 deaths are in people under the age of 60. The underlying health conditions, you know, we've seen patients in our hospital with several underlying health conditions, and also patients that don't really have any significant underlying health conditions have severe COVID. Typically, the folks that have died have been as a result of, have been in combination with other health issues. But we have had a couple of patients who did not have significant additional health problems. The biggest thing about people under the age of 60 getting COVID, and the fact that so many people don't have symptoms, younger folks may not get as sick, may be asymptomatic, may not even know they have it, but they're around older people. And so this can be spread from younger folks unwittingly, in a very cavalier way, just being around folks and spreading it to older folks who then get sick and then have a bad outcome. So, you know, how you decide what to do with younger people and how younger people approach this is an opportunity to take stock in your concern for society in general. I mean, it really just comes down to love your neighbor. You know, love your neighbor, do what's right for your neighbor, and cover your face. And that way, you don't need to know whether or not you've got it. You're protecting people. If you're an asymptomatic carrier, you're protecting people. And when somebody sees you in public with a mask on, what they see is a caring individual who's concerned about their fellow citizens. I think that pretty much covers what I needed to talk about today. I appreciate the opportunity. Thank you.